Hello and welcome. Today, we're diving deep into a really crucial topic for any of us who perform procedures, preventing the very infections that our interventions can sometimes cause. We're going to break down the evidence-based antibiotic protocols for things like PEG placements and ERCPs, all to make sure our procedures are helping, not harming. So here's our game plan. First, we'll get a handle on the risk and pinpoint the microbial threats we're up against. Then we'll talk about why we use prophylaxis before jumping into the specific practical protocols for both routine and more complex cases. And we'll wrap it all up by driving home the core message of prevention. Let's be really clear about what we're focused on. We aren't talking about treating a disease someone already has. This is all about preventing a complication that comes directly from what we do, from the moment our instruments breach the body's natural defenses. And because of that, the stakes are incredibly high. So to put a fine point on it, an iatrogenic infection is one that we, the medical team, cause. It's not like a community-acquired pneumonia or something a patient picks up on the ward. Nope, this is a direct result of a procedure. Our entire goal is to make sure our interventions are only therapeutic, not the source of a whole new problem. And these are the specific outcomes we're trying to head off. For PEG placement, the big one is a peristomal wound infection. When you get into ERCP or other biliary work, the feared complication is cholangitis, that dangerous inflammation of the bile ducts, or maybe even a localized abscess. Each procedure really does have its own unique infectious risk. Now, if you want to prevent these infections effectively, you've got to know your enemy. And that means understanding exactly which microorganisms we are most likely to introduce into the system during these procedures. This really lays out the battlefield for us. You can see that for both PEG placement and ERCP, the main threat comes from the patient's own aerobic intestinal bacteria getting into the wrong place. But when we shift to more direct biliary work, the focus sharpens, zeroing in on the Enterobacteriaceae family. Pinpointing the right pathogen is absolutely the key to picking the right antibiotic. So, we have the intelligence. What's our move? Well, we employ what you could call a preemptive antimicrobial strike. This isn't about chasing an infection that's already running rampant. It's about stopping it from ever getting a foothold in the first place. And the core principle here is just beautiful in its simplicity. The whole goal is to get bactericidal levels of an antibiotic into the tissue right at the moment of the incision or when we first introduce an instrument. For most of these procedures, a single targeted IV dose right beforehand is the standard of care. It's minimalist, it's effective, and it's a perfect example of good antimicrobial stewardship. Okay, let's get down to brass tacks. It's time to walk through these specific, actionable protocols for these key procedures. Think of this next part as our clinical field manual. All right, case number 1. A patient is coming in for a PEG placement. As we just saw, the main risk here is a wound infection right at that insertion site. And it's caused by dragging the patient's own gut flora through the abdominal wall. The protocol couldn't be clearer. We give 1 gram of cefazolin IV as a single shot just before making that first cut. Cefazolin, being a first-generation cephalosporin, is perfect here. It has excellent coverage against common skin bugs and the gram-positive aerobes from the upper GI tract, basically neutralizing the threat before it even starts. So just to lock this in, if you're getting ready for a PEG placement, what's the antibiotic that should immediately pop into your head for prophylaxis? Yep, it's cefazolin. Let's shift gears to our next case, ERCP. Now, this is a totally different ballgame. Unlike with a PEG, giving antibiotics for an ERCP is not something we do for everyone. It's only indicated in a very specific situation. And here's why we have to be so precise. The rate of bacteremia after an ERCP can be as high as 11%. I mean, let that sink in. That's not a trivial risk. It's a serious potential complication, which is why getting this decision right is so incredibly important. And here is that critical distinction. We only give prophylaxis when we expect that we won't be able to achieve complete biliary drainage, like when we know there's an obstruction. See, that obstruction creates stasis, which is like a perfect breeding ground for any bacteria we introduce. In that specific case, the protocol is, once again, a single 1-gram IV dose of cefazolin to prevent cholangitis. But if there's no obstruction, there's no routine prophylaxis. This really is the key decision point for any ERCP. The question, do we give antibiotics, hinges on one single factor. Is there a confirmed or highly suspected biliary obstruction? Nailing this distinction is absolutely essential. Okay, our final standard case involves patients who already have a biliary drain in place, and we're going in to manipulate it or perform a cholangiogram. Once again, the goal is to head off cholangitis or an abscess. Now, notice the tweak in the protocol here. It's still pre-procedural IV cefazolin, but we've doubled the dose, 2 grams. Why? Well, that reflects the higher bacterial load we often find with indwelling devices. And crucially, if we have prior biocultures on that patient, that data trumps everything. We should always tailor our antibiotic choice to the known sensitivities of whatever's already living in there. But what about when things get complicated? When we're moving beyond these standard procedures into really high-risk territory? Well, that's when a single pre-procedural dose just isn't going to cut it. So imagine this scenario. A patient is getting a liver tumor, treated with something like radiofrequency ablation or chemoembolization. And on top of that, they either have a biliary obstruction or a prior biliodigestive anastomosis. That combination just sends the infection risk through the roof, and it demands a much more aggressive prophylactic plan. For a situation this risky, we need a full multi-phase strategy. Phase 1 is the pre-op strike. We hit them with broad-spectrum IV coverage. Cefazolin for the aerobes, plus metronidazole to cover the anaerobes that are so common with biliary obstruction. Phase 2 is a 5-day course of post-op IV antibiotics to suppress anything left over. Then, if the patient is doing well, we move to Phase 3, a step down to a broad oral regimen to finish the course. This isn't just prophylaxis anymore. It's a full-blown peri-procedural treatment. So let's pull all this together. The one thread running through every one of these scenarios is the prevention imperative. Getting these protocols right isn't just an academic exercise. It is absolutely fundamental to making sure our patients have safe, optimal outcomes. And if you remember just one single number from our time today, let it be this one. We said it before, but it's worth saying again. Bacteremia rates post-ERCP can be up to 11%. That is a more than 1 in 10 chance of a serious complication that we can directly prevent with our knowledge and our precise actions. That right there is why this all matters so much. And let's end on a forward-looking thought. The principles we've covered today are our best line of defense right now. But as we all know, the microbial world is constantly changing. So the final question for all of us is this. As pathogens inevitably evolve and their resistance patterns shift, how are we going to adopt our own prophylactic strategies to make sure they stay effective? That's the challenge that lies ahead.